Dr. Denis Xavier.
Yes, I'm here.
Yeah.
Shall I go
Yeah.
ahead?
Yeah. Please go ahead. Please go ahead.
All right. Okay. Is my first slide visible? Population attributable risk.
Yeah.
Yes.
Right. Okay. The first time I heard about this was when the Interheart study was published, and I'm sure all of you have read about this, classic study, and it's been included in amongst the vintage papers of the Lancet over the last century or so. So let me use this example and dive straight into what is the meaning of population attributable risk, and I'll give you examples from this study as well as another study that we were involved in, which is the interstroke study. But before that, I want to tell you that the Interheart study was preceded by a simple case control study that Dr. Prem Pais did at St. John's, just a few hundreds of patients of myocardial infarction, and that was published in the Lancet a few years prior to this. And that was almost like a pilot study. And then Dr. Salim Yusuf and Dr. Prem Pais and a few others who you can see on this designed the study. I was very fortunate to attend most of the meetings of this Interheart study. So this is the last few lines of the Interheart study. So after the title, I'm showing you straight away the conclusion. And let me bring up a laser pointer here to say that our results suggest that approaches to prevention of coronary artery disease can be based on similar principles throughout the world. Therefore, modification of currently known risk factors has the potential to prevent most premature cases of myocardial infarction worldwide. If you go back to our discussions in the mid and the late 90s, there were a lot of discussions about what causes a myocardial infarction, and there were a lot of genetic issues that were coming up, a lot of biomarkers that were coming up. And then they said, amongst Caucasians, it's different. Among the Africans, it's different. Among Asians, it's different. Among men, it's different. Older people, different. Younger people, different. And there were a lot of, policies and plans being made for varying levels, varying types of risk factor control. So an important concept of doing, I'll just go back a bit, an important concept of doing a large international multi-center study involving almost 27,000 individuals, never done before, came, and with a study like that, with extremely robust statistical analysis, these conclusions could be made. So following this, people realized that common well-known risk factors account for over 90% of the risk factors for a coronary artery event across ages, in both genders, in all regions of the world, right? And therefore, modifications of these risk factors has the potential to prevent premature case of myocardial infarction worldwide. So the PAR, or the population attributable risk, was an important concept that was able that enabled the investigators to come to a conclusion such as this. So this I have taken from the statistics section of this classic paper. Population attributable risks and 99% confidence intervals were calculated for various risk factors, and how they did it is all clearly mentioned in this article in the Lancet that was over 20 pages. So this is a key result, and I'm taking it straight from the journal. So next time we look at the journal, it'll make a little more sense to us. So there are 9 risk factors here. Smoking, these two are smoking, diabetes, hypertension, obesity, abdominal obesity to be precise, not just BMI, psychosocial effects, vegetables and fruits, not just diet in general, but vegetables and fruits, exercise, and you'll see an asterisk here. Okay, we'll ignore that for now. Then you have lipids, ratio of ApoB versus ApoA1 in 4 different comparisons here. These were compared, and all of the above risk factors combined. So what we're going to see here one by one is different parameters that we will understand step by step. First, what is the prevalence in the controls? So 27% of the controls smoked, 48% we're also former smokers. Diabetes just about 7.5%, hypertension 22, obesity around 33, etc. So this is the prevalence and the controls. And if you see amongst the cases here, all of this except a couple are higher amongst the cases, right? 45%, or let's say here 48% smoking versus 65% smoking. Diabetes 7.5 here versus almost 19% here. So clearly, in all except vegetables and fruits where it went the other way, and exercise where it went the other way, and clearly we know that these are protective. So cases had lesser prevalence of healthy habits, both in diet as well as in exercise, and these are lipids. All right. So what do we see first? First, we see a 99% confidence intervals with the odds ratio adjusted for age, sex, and smoking. This is odds ratio 1, right? So this is the point estimate. Let's take this one, 2.3. So 2.3, and this is the confidence interval, 99% confidence interval around it. See how tight it is. 2.11 versus 2.44, around 2.7. This simply means that if you are a current or a former smoker compared to a person who's not smoking, the chance that you would have a myocardial infarction is 2.3 times more. And this is the 95%, 99% confidence interval around it. And we look at this all across, and these are the different odds ratios. And whenever you have an odds ratio less than 1, means that it is protective. So compared to those who or you have an odds ratio of 0.70, or if you consume vegetables and fruits on a regular basis, there's a 30% chance, that 30% lesser risk of you getting, of an individual getting in this population a myocardial infarction, and similarly for exercise, right? And this is the odds ratio for all of them combined. Now let's look at the topic of our discussion today, the population attributable risk. For smoking, now you will see percentages here. For smoking, it is 36%, and this is the 99% confidence interval around it. For diabetes, it's 12%, hypertension is 23%, obesity, it is 34%, etc. Right? And then there's something that I've blanked off here in the end. So clearly these percentages don't add up to 100. Usually percentages in a table add up to 100, but they don't here for an important reason. And let me tell you what the last thing that is hidden here. This is for all of the above risk factors combined. This is the population attributable risk, and the population attributable risk is 90.4% and a very tight confidence interval around it. What does this mean, right? These 9 risk factors account for 90% of risk of getting a myocardial infarction, and this is all well known. If you flip it over, of what we don't know, all the genetics and all the biomarkers and all the things that we still don't know, including infections and everything else, accounts for less than 10%. So that's how they came to this conclusion that these common, well-known risk factors, if we control them, and all of them are preventable, right? All of them are preventable. So clearly we cannot change anything about age, we can't change gender, right? And it is taken care of, it's accounted for, it's adjusted and removed, right? So 90% is what accounts for this risk. So for those of you interested, this is the statistics which I will skip through, and this is given in the paper. And for those of you interested in finding out how exactly they calculated this, and it's actually explained nicely if you want to read that. So let's, with that illustration of this very famous paper that many of us were involved in, let's come to the definition, right? Population attributable risk is the proportion, proportion of incidence of disease in the population that is due to the exposure of the risk factors that we measured in that population. Let's put it in another way. Let's have another definition. Sometimes complementary definitions help us to understand a situation better. If you want to remember between the two, maybe the second one is easier and better to remember. PAR is the incidence of a disease in the population that would be eliminated if exposure to that risk factor were removed from that population, right? So let's go back to this, right? Smoking, current and former smokers. So if in this population, everybody stopped smoking, right? So 36% of the risk of a myocardial infarction due to smoking would reduce. This is very important. So now, how is this important for policymakers? They will look at which is the largest PAR here. Let me go and address that. So if you look here, it is lipids, right? ApoB over ApoA1. So 54% is what it accounted for. And the next one was obesity, right? So if you take both of this, it contributes a huge amount to myocardial infarction, right? And then what about smoking? That comes next. So let me address smoking. And this is how public health policies are implemented. And that's how we researchers and statisticians all put together can come up with studies like this, which can change our understanding of a particular condition. Let me complement this with a more recent study done by more or less the same group. Dr. Prem Pais and I were involved in the study as well. This is Interstroke, done in 32 countries. And again, 27,000 people were involved in this. And now we have ischemic stroke and intracerebral hemorrhage, right? This is the PAR for all strokes, right? And we know the PAR for all strokes in Western Europe, North America, and Australia in 89%. For ischemic and hemorrhagic stroke, these are the differences. Let's take South Asia here. So the risk factors that we measured accounted for more than 90% of the risk overall. So this is by region also we are able to look at it. So and you will see there are very small differences between these regions that we studied. So this is an important table. It's very small. So I'm going to enlarge this in another, in the next slide and tell you this, right? So this is self-reported. This is history, just like the same one. I've not blanked it for now. These are the different risk factors in men and women for all strokes and what is the PAR that we are seeing. So we see here that the PAR for hypertension is quite high, 45 in men and 52 in women. Smoking is 16 in men and just 5.3 in women, right? Waist to hip ratio, 12.7 and double that in women. And this is for diet. And moving on, physical activity, diabetes, alcohol intake, psychosocial factors, cardiac causes, lipids again, and composite PAR for all the 10 risk factors in men is 90.6 and in women 90.6. So now we have 10 risk factors that we measured for strokes. Again, 27,000 individuals from all regions of the country, 35 odd, all regions of the world, 35 odd countries, and we were able to answer this. And now we have the opportunity of comparing strokes with acute myocardial infarction as well. And while the general scheme seems to be similar, there are small differences here and there, and we'll leave it now. So with this, I wanted to illustrate without going into calculations or statistics as to what PAR is. I'll go back quickly and just conclude with this slide for PAR, right? It's a proportion of incidence of disease in the population that is due to the exposure of this risk factor. If there is smoking, what are the proportion of smoking in the population we calculate, and then we look at in the case and the control, and keeping all that, we estimate it. And for that region, for that population, we are able to tell how important this risk factor is for that particular outcome. And this is interheart. So if it is interheart, it is for acute myocardial infarction. If it is interstroke, it is for strokes, obviously. If you want to look at another definition, incidence of disease in that population that we remove if this entire risk factor is removed. So that's what gives us. And then we can even, in terms of policy and other ways, we can, in an incremental manner, work on that. So with this, let me move on to the next chapter, which is a forest plot. Before we reach the forest plot, we need to look into a few other things, which is, how do we get the forest plot? We get a forest plot with a systematic review, which leads us into a meta-analysis. And we'll quickly look at the need for methods in systematic reviews, as well as how and when to undertake a meta-analysis. How do I pool data for a meta-analysis? And finally, construct a forest plot. And the topic of today is, how do I read, understand, and interpret a forest plot? Why systematic reviews, right? We're all familiar that there is a lot of data that's coming in, information and evidence is unmanageable, and systematic reviews help us to identify, collect the data, appraise it, and synthesize evidence, right? And it's presented in an accessible format. Now, if you want lipids and myocardial infarction, there are probably 30,000 articles. But if I narrow down my question, lipids, older people in India who already have some other condition, then maybe I will get 47 articles. And from those 47 articles, can I make a conclusion is something that we can do with a systematic review. So what's the definition? It's a process to collate all evidence that's available that fulfills a pre-specified eligibility criteria. It's not like a textbook chapter. A textbook chapter is according to that particular author or authors, but this is a research process, and it must fit a pre-specified eligibility criteria to answer a specific research question. Unfortunately, MCI does not recognize systematic reviews as a research original research paper, but I'm sure all of us know. If you look at the evidence pyramid, we start with case reports, case series, etc. If we come right on top, we come to a randomized controlled trial, and what's even above that is a systematic review and meta-analysis of randomized controlled trials that gives us the best level of evidence. So systematic reviews and meta-analysis are a very important research design and something for us to look forward to. So the method is explicit, systematic, reproducible as well. I didn't write that here. And to minimize bias, we need to provide reliable findings and draw conclusions to make decisions. How do we search for studies? Our search must be thorough, objective, and reproducible to identify all, I shouldn't say as many, I should say all relevant studies as possible. Midline, which is freely available alone, is not enough. Depending on what topic we are looking at, we may get only as low as 30% of the articles, or at least or up to 80% of the articles. So we need to use other databases such as Embase, Sinhal, and many others to put all of our data together before we make conclusions. How do we summarize findings? So we put all of them together, and I'll give you examples shortly. We collect all of these data based on our objectives, and we make tables. One of the toughest things that we have to do is making these tables that have possibly 37 rows and 12 columns, and we do that in Excel or Word, and then we do it over and over again till it makes sense for us. Then we analyze this. How do we analyze this data? We can narratively analyze it by recognizing patterns. Oh, there are more older people here, there are more men here, more women here, this quality is not so good. So the human mind is pretty good at pattern recognition, right? And then we can summarize that data to some extent. However, this stops at a narrative analysis. The next step is to undertake a quantitative analysis, and that is what a meta-analysis is. And I will tell you, the rest of the talk is about meta-analysis and the forest plot that comes. So let me quickly give you an example of a systematic review that we conducted recently, which is looking at the prevalence, risk factors, and awareness of hypertension. We did, but the example that I'm going to show you is on coronary artery disease. And also we look at another example that colleagues from Canada did, looking at beta blockers on perioperative ischemia. And this is a systematic review done before this trial POISE was done. So this we published in the Indian Heart Journal, and happy to tell you that Dr. Iyengar is also one of, and Dr. Kiran Verghese, I think he is on this call, and many friends from different parts of the country were involved in the systematic review, looking at the prevalence, treatments, and outcomes of coronary artery disease in India. And we were all mentored by Dr. Prem Pais as we conducted this. So we looked at 3,885 articles. That was our first search. And after multiple processes, which took us a few months really, we narrowed down to 288 articles, which we took on which we conducted systematic review on. So table 8 over here, I skipped the first 7 tables, gives us the outcomes reported among MI patients. Right from 1972, we found articles, and we came down. Some of these are, this is another paper that Dr. Prem Pais was involved in, and this was also conducted in St. John's in 1999. And this is the CREATE paper, which had 20,500 participants. And this is Dr. P.V. Mohanan's paper, the Kerala registry, on 25,000. He was very keen on going a few thousands more than CREATE. We did have a nice interaction, discussing these numbers. So outcomes on mortality, death, reinfarction, stroke, etc. in hospital 30-day and 3 to 6 months. If you just look at this, so firstly look at this. We're talking about acute MI in a large country of over 1 billion people, and sample sizes of 1,000. Only 2 studies went over 20,000. And again, here we don't have much data. In fact, the conclusion of this paper was we need good articles. We need good research done particularly. And if you see here, over 6 to 36 months, there were just 2 papers which went to 1 year. No paper or no research went beyond 1 year. So that was a key conclusion, and there was so much of variability between the studies that we found that we did not even undertake a meta-analysis. So let's look at another paper which was done by a good friend of ours, Dr. P.J. Devereaux, who's a cardiologist from McMaster University in Canada. He looked at how strong is the evidence for the use of perioperative beta blockers on cardiac surgery, a systematic review and meta-analysis. This paper was one of his 3 papers that he published or that he presented for his PhD defense at McMaster that I was fortunate to attend. So he initially, or his team initially, identified almost 5,000 papers. Most of them were non-randomized trials or non-randomized studies, so they were all excluded, and in the end they had only 22 papers that they were able to analyze for this research question: use of perioperative beta blockers in non-cardiac surgery, right? And this is table 1. It actually goes to 4 pages on both sides. All these 22 papers were summarized here. This is the year of publication, how many were randomized, very small numbers, as you can see. We're talking about randomized controlled trials of beta blockers in non-cardiac surgeries, and very few numbers at that time. Type of surgery, what intervention, what drug. So if you see here, in just 2 lines, so much of information is given. 2 milligrams or 4 milligrams of metoprolol or placebo injected just before anesthesia. Esmolol here, metoprolol or placebo here, drug doses and length of follow-up, and outcomes elsewhere given. So this is table 1, which summarizes all of the studies that were done. So what is a meta-analysis? Meta-analysis is a statistical technique for combining the results of 2 or more studies. At least 2 studies we must have to combine them. And all these studies have asked the same research question. We may have different populations. They must all use beta blockers, but they can use different types of beta blockers, right? They can have different doses, different routes, etc. But they must all ask the same general question, only then we put them together. Now we can pull results from any studies. They can be observational or even intervention studies. And of course, high quality meta-analysis only pulls data from systematic reviews, ensuring that we've collected all of the studies that have been there. There are 2 methods to pool. There are 2 pooling methods. So before I show you these definitions, which are actually a little complicated, I'll not show it to you right now. So there are 2 methods to pool data, right? Pooling data just is not an arithmetic or any other average, right? Suppose one study had a risk reduction of 10% and another study had a risk reduction of 15%. If you pool these 2, it's not an average of these 2, right? You will not get 12.5 as the pooled result, right? There are 2 ways in which we pool data. One is called the fixed effects model. The other is called the random effects model. If you try to read this, it's pretty complicated. So I'm going to go back and I'll tell you the difference between these 2 models in simple English. A fixed effects model pools data when the studies, and we're going to measure this statistically. We're going to put all of this and measure whether the studies are similar to each other or are they different, right? I'm using simple English here. Technically speaking, are they more homogeneous or they are more heterogeneous? There are 2 types of heterogeneity. One is clinical heterogeneity and the other is methodological heterogeneity, right? Now, okay, in the interest of time, I'm not going to explain more on types of heterogeneity, but let me tell you these 2 types of pooling. If the studies are more homogeneous, I would use a fixed effects model and I'll get a nice precise estimate. However, if there is more heterogeneity, the studies are more dissimilar, they all ask the same research questions. It's all perioperative ischemia, non-cardiac surgery, right? They all use beta blockers, they all followed up patients, they're all randomized. However, they use different doses, they had different age groups, older, younger, short follow-up, long follow-up, all of that. So it brought in quite a bit of heterogeneity, and that is measured. And we use different softwares. RevMan is a free software available in the Cochrane website, and we can use that. And in fact, the software itself will recommend that you use this particular kind of a pooling method. So these are the 2 pooling methods: fixed effects methods or fixed effects models and random effects model. Most studies use the random effects model, right? Because studies are heterogeneous. number one. And number two, it's a little more conservative and it's a little more easier to get the reviewer, particularly the statistical reviewer, to accept your paper when you submit. So for all practical purposes, better to use the random effects model based on the heterogeneity. To conclude, sorry, is there something? I heard somebody talking. All right, okay, this is my last but one slide, and I will conclude with this, and this is the topic of today, and I had to do all of this to reach this topic, right? So this is the title, Relative Risk of Major Perioperative Cardiovascular Events, which is death, non-fatal MI, or non-fatal cardiac arrest. So follow me one by one, and I will use this laser pointer to help you follow. So 1, 2, 3, 4, 5, 6, 7, 8 studies were included for this meta-analysis. But you will recall that there were 22 studies that were included in the overall study. But these 8 studies had these outcomes. This is the beta blocker group. This is the control group, right? Now, N by N, 1 is the event out of 18 people. Here, no events in 18 people. So the sample size of this study is 36. The sample size here, 99 plus 101 is 200. Sample size here is 99, so on and so forth. So the first number gives you the number of any one of these events, and the next number is the sample size in this group. So if we come right down, we have 589 plus 563, about 1,100 and odd patients totally in these 8 studies, giving us 19 plus 22 events, right? So totally we have 41 events. Oh, I'm sorry, 41 events in this. Sorry, we don't have number of events here totally. But if you add up all this, we'll get the number of events. So this is the total sample size, and these are the events, and these are the numbers here. This is now the forest plot. The bold vertical line is the line of no effect. Since it is risk, it is 0. If it's a ratio, if it's a relative risk reduction or an odds ratio or a hazards ratio, we'll have this as 1, right? Any depiction on the right of this favors control, any to the left of this favors treatment. So I'll take you step by step through each of this. So this box over here is the point estimate of the relative risk, and the line across is the 99% confidence interval for this particular study, right? Now, quickly, when we eyeball this, we find that all of the studies are crossing the line of no effect, except one. Except one, they're all crossing the line of no effect. That means all of these studies results are not, individually, they are not statistically significant, except this one study, right? So the size of the box, you will notice that the size of the box also varies. This is not a printing error. This is the size of the box. You see here and here, you will have a difference. The size of the box indicates the amount of information that that study provides to the meta-analysis. So if you see here, this study by Homer Yang, in fact, he's an anesthetist in McMaster University. When he was working there, he moved on. So his study is one of the best studies in this meta-analysis, and therefore has the biggest box because it has 41 events and close to 500 participants out of an overall 1,000. So his study gives us more than half the information if you look at it this way, right? And this study is much smaller, smaller, smaller. This is the only study that shows statistically significant results. But let's look here, right? Beta blocker group, there were only 2 adverse events, whereas there were 18 in the control group. So this is hugely statistically significantly different effect that we find here. And in a way, this study is somewhat dragging the pooled effect towards the end. Now, let me conclude this part by explaining to you what is this. This is the diamond, or this is the pooled effect of all of these studies. Right in the middle of this is the pooled effect, and the edges of this diamond is the 99% confidence interval in this. Now, for each of the study, we calculate a weight. This is not PAR now. This is the weight that each of the study contributes to the overall study, and this adds up to 100. And you will notice here that almost a third of the weight is contributed by Homer Yang's paper here, which was very good. And whatever we are seeing here is given exactly here. So do you see 3 over here? This is 3. right? And this is the 99% relative risk, right? And 0.61, you see 0.61 over here, and this is the 99% confidence interval, right? The pooled estimate is 0.44 over here, or in other words, beta blockers cause a 56% reduction, or enables a 56% reduction in these events compared to control or placebo. Even a 56% reduction is not statistically significant. As you see, this crosses 1, and this diamond crosses this line of, crosses 0, I'm sorry, here, and crosses this line of no effect, right? So this is how we read and interpret a forest plot. Just on the side, I just want to let you know that this gentleman, Polderman's, if you, those of you interested in scientific investigations and fraud, you can read up about Polderman's. His data in the end, and all his studies were investigated, and it was found not to be authentic. But this was all found many years after this. So friends, to conclude, and to give you a summary of the forest plot, just before that, a systematic review and a meta-analysis gives us the highest level of evidence, can be done with little resources, a bunch of people sitting anywhere. Even if there's a lockdown, we can conduct this research and many part of the world. Answers or resolves important clinical questions. It is an important tool for evidence-based healthcare, and it's critical for guidelines committees. So all guidelines committees use systematic reviews, meta-analysis to make their decisions. And of course, for better patient care, even if the guidelines committees say that, we can look at a systematic review, meta-analysis, we can read the forest plots, and we can find out for us how good it is. And now we have many more systems that have come up, largely led by people in McMaster University, like the Grade Pro, and other mechanisms have come up. You can get the same thing on your phone, on your iPad, on a regular basis. So to conclude, a forest plot is a graphic display which depicts several parameters in a well-organized manner for us to quickly read and understand and take our decisions. Thank you very much for your time, for the opportunity, and I'm happy to help, and I can be reached here on this email, and all of these slides I'll be happy to share with you. Thank you very much once again.
Thank you, Professor Dennis. It was a very lucid and lucid exposition of both the subjects, that is the PAR as well as the forest plot. As you mentioned, the population attributable risk basically is a way of looking at the risk factors in a given population. So it's of public health importance for policymakers, absolutely. And you really put it through two important trials done, you being one of the main investigators in InterHeart, both the heart and the interstroke study. The second part, the forest plot, also you lucidly elucidated the way a meta-analysis is represented graphically and how easy to capture the data and present the data. So we have some questions. Dr. Ishwar Prasad is asking, in the present COVID scenario, population attributable risk with regard to India and Western countries, it is hypothesized that BCG vaccination might prevent the population from getting infected. How to test this hypothesis? If we were to do this, how do we do it? So that's one question we have with respect to PAR.
Okay. How I mean, this is really
how to test the hypothesis, the BCG.
Yeah. This is really tricky now.
Yeah.
For us to test this particular hypothesis. People are talking
it would be
in different ways. So I'll try and answer this to the best of my ability, but I'll request my teacher and mentor, Dr. Prem Pais, to add to this, or even to correct me wherever I go wrong. Happy to be corrected. So the only way we can do this is to find people who have all been vaccinated by BCG, and find matching controls who have not been vaccinated with BCG, and then follow them up and see whether they get COVID positive or not. And the way to do this is by using a case control study, and then we can compute the population attributable risk in a similar manner. I'll stop here with this brief response and request if Dr. Prem Pais would like to add to this, or even tell me I'm wrong.
No, Dennis, you're the expert now. No, I think the way to answer that question would be the same way as you answer as we did the interstroke study. We are looking at risk factors for a disease. And remember, risk factor, we say it's positive when it causes disease and is negative when it prevents disease. So in this question, we will expect to find that BCG vaccination is a negative risk factor for developing coronavirus. We can't do a cohort because you'll have to wait for centuries to get enough people with the disease. But instead, if you have a population where many people have a BCG and many don't, then you get people who have coronavirus, you match them with similar people who don't have the infection, and you see how many percentage in each group actually got the BCG vaccination. With that, you can calculate the odds ratio. And once you have the odds ratio, you can convert that into a population attributable risk. I think that would be the way to go about it.
Thank you, Professor Prem Pais, for clarifying that. We have another question from Rahman, Dr. Abdul Rahman. He is asking, is it compulsory to in a meta-analysis to have only RCT for the forest plot?
Sorry, I didn't get that question.
Is it compulsory in depicting a forest plot to use only randomized controlled trials?
Oh no, I did clarify that in my slide itself. So a forest plot is just a depiction of the results of a meta-analysis, and we can use different data to pool. In a meta-analysis, it can just be prevalence data, incidence data, observational studies. Also, any data can be pooled, ratios can be pooled, etc. Right? So now most of the forest plots that we see are based on randomized controlled trials, and those are the ones that give us evidence to take decisions about our patients, and therefore the best evidence for any treatment comes from a randomized controlled trial. And then of course, as we start off, randomized controlled trials give you varying results, and as we progress and do larger and larger studies, actually it goes up like a funnel, and then we get larger studies, give us more precise estimates, and then we put all of these together, and then we get a pooled estimate, and it need not be only from a randomized control trial.
Professor Denis, in fact, most of the questions are with respect to the kind of data you have to choose, because there are two more questions on the same lines. With respect to meta-analysis, what kind of data should we select? One more question is it necessary, in your opinion, to use Zadard scale for shortlisting of published papers for meta-analysis? Is one more question Dr. Madhavan has asked.
I think it's the same question come twice. The first question I've already answered, which is what types of data. So Alex Haddad, the J is silent there, he was also from McMaster University. Now he works in University of Toronto. So he came up with different scales. So, okay, one thing that I did not have time to speak about today is, of course, we have eligibility, like we have eligibility criteria for patients to be included in our study, observational or randomized controlled trial. Similarly, we have eligibility criteria for papers to be included in a meta-analysis. Even if they fulfill the criteria, we look at the quality, right? And then as we all know, what we put in, only that comes out. So we put in garbage, we'll get only garbage out. Therefore, we can have a cutoff and say, up to this level of quality, I will accept. Beyond that, I will not accept. And all the papers that you have rejected, we actually list out in an appendix and say, these are the papers rejected and rejected. So in fact, when I was doing my course, we had to undertake a meta-analysis, and we had to create a modified, another colleague of mine and we looked at stem cell therapy for post myocardial infarction outcomes. And then some papers we had to reject for different reasons, and then we put it. So Haddad scale is one of the criteria, one of the methods by which we can do it.
Take over.
Good evening, everyone. We have come to the last topic of the session. There are various trial designs. More often so, we hear about superiority and equivalence trials. But what is the application of non-inferiority trials? We will hear from Professor Pais. Over to you, sir.
Okay, I'll just enlarge the screen. Am I audible?
Yes, very clear.
Am I audible?
Very
Yeah,
clear.
perfect.
So good evening, and I'm happy to come in at this end of today's session. And I'm going to talk very briefly on non-inferiority trials. I'm not going to go into technicalities and all that, but I want you to understand when we do and why we should do such trials. The usual trials that we do are superiority trials, in which we are trying to prove that the medicine or whatever intervention we are interested in is better than the control arm. To give you an example, in the SPAF trial, the old one, stroke prevention and atrial fibrillation, where we compared warfarin with the placebo, it was a superiority trial, and the trial clearly showed that warfarin was 67% reduction in relative risk of stroke compared to placebo. And we could very confidently say that warfarin was superior to placebo in preventing stroke in non-valvular AF. This is the kind of analysis, or at least plan of analysis, that we do in a superiority trial. We set a null hypothesis. You know, we have this rather odd way in statistics of first having a null hypothesis and trying to disprove it. So the null hypothesis in a superiority trial is that the new treatment is not better than the control treatment. And our alternate hypothesis is that the new treatment is better. For us to say that our alternate treatment is true, we have to show that the null hypothesis is disproved. So let me come back to SPAF. And that's what SPAF showed. Warfarin versus placebo gave a relative risk of 0.33, that is about 67% reduction. And the confidence interval was well within 1. P was less than 0.05. And we could say that we have rejected the null hypothesis, accepted the alternative hypothesis, and warfarin is superior to placebo. But look at the Charisma trial, which compared two antiplatelets to aspirin alone in stable coronary artery disease. Here too, the relative risk was reduced by a reduction was 7%, small, but it was there. But when you look at the confidence intervals, you will see it crosses 1, and the P is more than 0.05. So unfortunately for the Charisma investigators, they could not reject the null hypothesis, and all that could be said was that aspirin and clopidogrel are not superior to aspirin alone. They couldn't say anything else. They couldn't say it's as good because they set up a superiority trial. They were not able to reject the null hypothesis, and that was the end of the matter. But let's stay with this thing of anticoagulants. Now, we know warfarin is wonderful. It reduces stroke. It's well proven. It's standard of care. We also know it has drawbacks. It causes intracerebral bleeds. You need to do INRs. It keeps wearing. And now a new molecule becomes available. And preclinical animal and phase 1 trials show that they seem to have effective anticoagulation. They have stable PK/PD and seem to have even less intracranial hemorrhage. Now we have the companies planning to do a phase 3 trial to get marketing approval. Now the issue is, we know warfarin is very effective. And we also feel that it's going to be very difficult to show that our new molecule is superior to warfarin. But we are confident that even if it is almost as good, its advantages are so many that even if it is almost as good, they can still say that this is a useful drug. And that is how most of the clinical trials using the newer anticoagulants were designed. Rely and Aristotle, Rely was dabigatran and Aristotle was apixaban, and for that matter, the rocket with rivaroxaban. When they compared it to placebo, they always designed it as a non-inferiority design. Whereas Averroes, which was also using apixaban, but compared it to placebo in patients who are not suitable for warfarin, used a superiority design. Because when you're comparing to placebo, you can't go around saying, I want to show it's non-superior or non-inferior to placebo. If you're comparing to placebo, it has to be superiority. If you're comparing with an active drug, which you know is useful, but you feel your drug has some advantages, you can go for a non-inferiority design. So the non-inferiority design aims to show that the tested drug is no worse, that is non-inferior than the standard treatment. The advantage is that when you design such a study and once you prove non-inferiority, you can do a second analysis called a sequential analysis and look for superiority. But in your protocol itself, that I am going to do a sequential analysis. If non-inferiority is proven, then I will analyze for superiority. If this is not stated upfront, then any superiority claim later on will not be accepted. When you are designing a non-inferiority trial, you have to be very clear of what do you mean by non-inferior. What exactly do you mean? You have to very clearly say that I wanted to capture at least so much of the benefit of the standard drug. That is called the non-inferiority margin. And as I mentioned to you before, you would only use this design in active control trials and not in a placebo control trial. These are the kind of hypothesis statements that you would make in the three different designs. In superiority, we have already seen what we would state. In a non-inferiority, your null hypothesis would be that the new treatment is inferior to the control. The alternate hypothesis is the new treatment is non-inferior to control. And if you have planned sequential analysis, you would say null hypothesis is the new treatment is non-inferior. This is for the second part of the analysis, but it is not better than control. And the alternate is it is non-inferior and is better. So if you go for the sequential, you have to first prove non-inferiority, and only then can you proceed to test for superiority. How do you arrive at this non-inferiority margin? You have to also define this in advance. I'm not going to go into all the details of how you calculate it because I don't understand all the calculations myself. But basically, you have to see how much the standard treatment benefit is compared to placebo. In the examples we took, you want to find out by doing a meta-analysis that Denis spoke about, how much advantage does warfarin have over placebo? And you say, I want to preserve at least approximately 50% of that advantage before I call it non-inferior. So you take account of the benefit that the standard treatment has over placebo. We identify the lower margin of the confidence interval of the comparator, that is warfarin, let us say, to placebo, and we call this M1, margin 1. And you, as I said, often have to do a meta-analysis of many studies to arrive at this margin. And then you set your non-inferiority margin to preserve 50% of that, and you call this the non-inferiority margin, or M2. Later on, I have a little diagram to make this a little clearer. Let's look at this. This is Rocket. Rocket is rivaroxaban versus warfarin, and it was a non-inferiority design. And you could see it had a hazard ratio of 0.88, that is a risk reduction of about 12%. They set a non-inferiority margin of 1 point. Unfortunately, I don't have a pointer that works. I don't know. Can you see the pointer? Probably not. It has a non-inferiority margin of 1.4.
We are able to see the pointers.
Pardon?
We can see the pointer.
Okay, 1.46. And their low confidence interval here is 1.03. So it meets the non-inferiority standard, and the non-inferiority p-value is less than 0.05. So you have rejected the null hypothesis of the non-inferiority part of the analysis. But when you sequentially did the superiority, you see it has crossed 1. The p-value drops to 0.12. And in Rocket, rivaroxaban was non-inferior to warfarin, but it was not superior. Compare this. This is a very interesting one. Rely is very interesting to study non-inferiority analysis. In Rely, we had 3 arms. We had a control arm on warfarin and 2 arms on dabigatran. One arm had 110 milligrams twice a day, and the other arm had 150 milligrams twice a day. With the 110 milligram arm, you got a hazard ratio of 0.91. That is a 9% reduction. They also set a non-inferiority margin of 1.46, which was achieved. 1.11. So the non-inferiority part, you could say that dabigatran 110 was non-inferior to warfarin, right? But it did not meet the superiority part because it crossed one part. So the 110 milligram dose of dabigatran was non-inferior to warfarin, but it was not superior. But we know, which is not on the slide, that it was much safer with fewer bleeds. When you come to the 150 milligram dose, it met both the criteria. When they did non-inferiority, it was proven with a p-value of less than 0.001. And sequential analysis for superiority was also proven with a p-value of less than 0.005. So dabigatran 150 was non-inferior and superior to warfarin. So that makes it somewhat clear. And here I put it in the diagram. Here you see the central one is the null, where there is equal to warfarin, no benefit on warfarin. This side is warfarin is better. This side on the left-hand side is dabigatran is better. M1, you can see M1, this is the benefit that warfarin has compared to placebo. And so they set the non-inferiority margin about halfway between 1 and the placebo effect, and they set it at 1.46. This is M2 is the non-inferiority margin. And you can see with a 110 milligram dose, the lower end of the confidence interval crossed 1. And it was very far from the non-inferiority margin. So we could say it was non-inferior, but we could not say it was superior, which we could say for the 150 milligram dose, because here the lower confidence interval is not only within M2, it is also within the 1. So non-inferior, but not superior, non-inferior and superior. There's another design, which I'm not spending any time on it, but just because there's confusion, that is called equivalence. Equivalence is not the same as non-inferiority. Equivalence just tries to show that this tested drug is very similar to the other control drug, both directions, both within the two arms of the confidence interval. It does not look for superiority, and it looks for non-inferiority, but it does not look for superiority. It is not very commonly done. It is usually done by pharmaceutical companies when they're producing a new molecule and want to compare it with the old one. As you can see in this small paper by the Ascent 2 investigators, where they tried to compare various forms of the thrombolytic agents with TPA, NPA, tenecteplase, RPA, and they used an equivalence design, and they put both margins and said that all three had equivalence with TPA. So that is where you would use an equivalence design. Once more, just to make things clear, 3 simple lines. 0 would be the same effect as the control drug. Superiority, the drug has benefit, and even the lowest part of the worst possible scenario, it is superior to the control drug. In non-inferiority, it may or may not have benefit, but the lower confidence interval will not be better than the control drug, but it should be better than the margin that you have set to prove non-inferiority. And in an equivalence design, it will be more or less central, and both the confidence intervals will more or less match the confidence intervals that you have of the control drug. So now this is my last slide for the take-home message. The design of non-inferiority is chosen when testing a new treatment against an existing effective treatment. It may have other advantages. The new treatment may have other advantages. So you're willing to give up the same benefit, or maybe even give up a little bit of the advantage of the old drug if you have a lot of other benefits that may be. And the third advantage is you don't give up your chance for proving superiority once you have tested and confirmed non-inferiority. Thank you very much.
Yes, sir, for making us understand the non-inferiority trial design. We'll take up questions. Is a question like, is there any specific cutoff for the lower limit of non-inferiority margin?
Any specific cutoff? As I told you, there's no fixed specific cutoff. Obviously, it will be different for each kind of pair of drugs that you're choosing. But the general principle is, as I said, two investigators may be doing the same kind of trial. One may choose one cutoff, one may choose a slightly different cutoff. But the basic principle is you are comparing it with a drug that is already effective. So the first task you have is finding out how much benefit the control drug, the old drug, has over placebo. And your new drug must maintain approximately at least 50% of the benefit. So since warfarin had, say, 65% benefit over placebo, you would like, or 70%, you should get between 30 and 40% at least of that benefit should be left behind. So that's how you would arrive at a non-inferiority margin.
There is one more question, but I think it's already answered. How do you decide when to do a non-inferiority versus a superiority trial?
It's already answered, you know.
Yeah, I think so.
Yeah.
Dr. Prem.
Yes.
FDA had set up some cutoff for these diabetic drugs. What was that for? The cardiovascular outcome?
I didn't get the question. The voice broke up there.
FDA had set up a point for cardiovascular outcome of these new diabetic drugs.
Yes.
Does that correspond to non-inferiority?
It's a sort of a non-inferiority. I wouldn't know how you call it, but the idea is same. What they wanted to prove is the FDA didn't want to prove that the diabetic drug is superior to placebo. They wanted to show you to prove, that is the drug pharmacist company to prove that it does not cause more harmful effect than placebo. So it was sort of a reverse non-inferiority. That means it is non-inferior in causing harm. So there they set the margins of what is the chance of the heart incidence or prevalence of heart disease in placebo arm of trials, and they removed that and wanted you to prove that the new diabetic drug falls within that. It should not cause more heart disease than placebo. Of course, manufacturers have tried to prove and have successfully proven in many cases that their drug actually has benefit compared to placebo and cardiovascular trials in diabetics. But the FDA's idea was it should cause no more harm than placebo in heart disease.
Thank you. Yeah, I could close, Dr. Nagamani.
They specifically ask for any specific cutoff points for lower limit of non-inferiority and cutoff for superiority trials that they've asked.
The
superiority trial won't have any cutoff. A superiority trial is proving straight off superiority. So there's no question of setting a non-inferiority limit. In superiority trial, you have to show that your point less than 1, and even the lower limit of the 95% confidence interval is also less than 1. So if you get a 0.7 and your confidence interval is a 0.5 to 0.99, you have proved superiority. If it is 0.7 and confidence interval is 0.5 to 1.01, you have not proved superiority. So the limit for a superiority trial is 1.
It should be less than 1.
Yeah.
Thank you, Dr.
Thank you, Prem Pais.
Srinivas, kindly conclude.
Doctors,
I hand it over actually to, if there are no other questions.
A couple of questions towards the end, and I'll try and answer them. One is hazard ratio, and last one is a non-inferiority about price advantage. But firstly, hazard ratio. So hazard ratio is, we actually discussed this yesterday with Dr. Tidy Nair in the Kaplan-Meier curve. But anyway, so hazard ratio is similar to a relative risk reduction, but with the time kept in mind, right? So you get a ratio. Let's say you get 0.85. So we say, so the relative risk is, or the hazard ratio is 0.85, and our conclusion is there is a 15% reduction in these events compared to placebo or control. And then we can look at whether this is statistically significant or not. So in simple terms, hazard ratio is similar to a relative risk reduction, which I'm sure we should be familiar with now, but with time kept in mind. And this is computed in survival analysis, which was discussed yesterday. Survival analysis helps us to, firstly construct the curve, and then to compare between the two curves. We have different tests, and the commonest test that we see, and it's published in many cardiology trials, is the Cox proportional hazards analysis that is done. So that's how we get a hazard ratio.
Professor Denis, and there is another question from Dr. Ravindranath KS.
Yeah.
How does meta-regression analysis differ from meta-analysis?
No, it's not different. Okay. So for that, we need to understand regression, which we have not done here. I'm not sure we're doing it tomorrow. So basically, if we get, in a meta-analysis, we apply the principles of regression analysis, and we try to find out what factors are driving the conclusions of a meta-analysis, and we're able to explain each of the different factors. So in a short while, without having discussed the others, this is the definition that I can give for a meta-regression. It's not different from a meta-analysis. It's only we try to explain a meta-analysis a little better.
The other two questions which should be answered with this thing, I think. One is PAR is applicable or reasonable in all types of studies, or only for the case controlled cross-sectional population? And Dr. Kiran Varghese asked, can relatively low PAR also be important when most of the population is exposed to the risk factor, as in case of environmental pollution? Okay,
Dr. Kiran Varghese actually asked a PhD level question here. Okay, so that's quite right, Dr. Kiran. If we have a ubiquitous risk factor, such as air pollution, which is everybody is being exposed to it, even if the level of exposure is very little, it does have an impact. Of course, Interheart, Interstroke did not measure it and publish it in the initial papers, but for Interstroke, we are actually looking at and the PURE study, which is a massive cohort study with over 2.5 lakh people being followed up over 10 years. They're doing very, very precise measurements, and we'll be able to find it out. So, Dr. Kiran, you're right. If there is a very low exposure, the amount of exposure is very little, but it's ubiquitous. It's everybody's being exposed to it. Then that becomes important for the population. Was there another question? I think we answered.
I think we should wind it up now. Dr. Iyengar, kindly.
Thank you, Dr. Denis and Dr. Nagamani. Thanks, Denis, for staying a little longer. Thanks,
Denis, thank you.
Greatly appreciate it. Thank you. And I thank all these speakers and all the chairpersons. And with this, we come to the end of this today's program, and hope to see you back tomorrow.
Dr. Prabhakar. Dr. Prabhakar.
Thanks to all speakers, trustees, and chairpersons, and all delegates for staying nearly for 2 hours with us. Thank you, everybody. And thanks to the sponsors, that is Microlabs, eMark, and the Mankind Pharma for giving us unrestricted grants for conducting this program. Thanks, everybody.